So I have 3 announcements, unless I get a wave from our competent volunteers that I've forgotten one. The first one is to thank again our volunteers for clearing out the hall last night and tucking all of the equipment away, getting everything set up this morning. So thank you again. And now they're enjoying a well-deserved breakfast. However, if you would like to demo again during lunch, we did reserve time to demo during lunch. Then please speak to the volunteers about getting the equipment set up again. We have that all tucked away in the back, and it's pretty quick to get set up. So for lunch demos, speak to the volunteers if you have the energy to do that. It was great to see such lively conversations last night. And then the last announcement is the bus company is not joking about having everybody start signing in at 5. They've told us that a bunch of times. And also you've probably received several emails from the Statler letting you know to check out at 11. So please do take the time during break to get checked out. You can leave your luggage there. And we are going to let you go a little bit early so you can all be sure to check in on the bus if you're leaving on the bus tonight at 5. I know some folks are staying late or leaving early. So thank you all. And we're about to get started with the panel in just a couple minutes. I'm excited to introduce our next panel. So we have Dr. John Rubin and Dr. Rohan Jotwani. And then we also have a potential guest panelist named Casper, who is a trial version of the sickle cell patient, Carl, but this is a new version who's never been demoed in front of such a large audience. So we are making history, maybe. So that's really exciting. So I think rather than me start off by asking a question, let's just see if we can get Casper going.
Sure. Well, let's just start by giving some feedback on or describing how we came about this. So I think we briefly described this yesterday, but Rohan and I for the past year officially spatial agents. AICAs for short. And basically what this is it's where we have there's an underlying large language model. And then we add in there we go. We add in a backstory for a character, and then we add on, context specific clues for the character, and then you begin to have a conversation with it. So that's one of the forms of the conversational agent. And we can use that, for example, to do standardized patient encounters. This is a little bit different. This is where we've actually uploaded information, like a book, for example, that somebody wrote about their experience with sickle cell anemia, for example, not exactly that, but something similar to that, into this platform. And it allowed us to create this character. The first character was named Carl, who was a patient who has sickle cell anemia. And the purpose of interacting with Carl is to gain insight into what it's like to have sickle cell anemia, and also to gain greater empathy for Carl and patients who have chronic pain like Carl. So I'll let Rohan talk a little more about Casper and how that fits in.
Yeah. So Carl, for those of you who weren't here yesterday, stands for Conversational Agent Relief Learning in Pain Medicine. But Carl Ipham kind of sounded silly, so we just shortened it to Carl. The question is why? Why are John and I creating these robots that emote pain, think about death? Like, what is have we lost our minds? To take the most vulnerable human emotions and try and get robots to understand them and mimic them. I use the word understand. There are going to be a lot of times where we confuse notions of consciousness. These robots are not conscious. I'm starting off this presentation saying what they do is a very fancy, convincing version of statistical portrayal. But to be fair, John and I deal with stressful situations all the time when it relates to things like pain and death, and suffering. And I will start off by saying that the thing that I tell every single person who I teach about pain is that we probably use the word pain wrong. And it took me halfway through my fellowship to kind of understand this. So when we think about concepts like pain, we think about mostly a signal from the body to the brain. But we never really think about the way that signal is processed. And we never really think that the word for that signal going to the brain is actually called nociception. Pain involves some element of suffering. There's something subjective about that experience. Hold on 1 second. Sorry, I'm just loading the experience again. So we as physicians sometimes need mentorship and guidance for how to talk to patients and how to keep up our own empathy when you're talking to 20 pain patients a day. These models are based off of literature that John and I think is very interesting, but it's like being able to talk to the literature, being able to like talk to a guide. It's like a mentor for us to be able to better understand the human experiences. I've asked Carl and Casper lots of questions that I've actually never asked patients before, because when you're talking to patients who live in chronic pain or are end of life, they don't often want to teach you, right? Like they're dealing with their own stuff. And it's not incumbent on them to be our teacher. That's an unreasonable burden to place on someone who is suffering. So this is sort of where that comes from. Let's just start by talking. So CASPER stands for Conversational Agent, basically about end-of-life care and relief and pain. So she actually has a much larger context than Carl does. She's actually also trained to talk about end of life. Good morning, Casper. How are you doing?
We need the audio.
I am an AI that is designed as an educational tool to help with topics related to palliative care, pain management, patient experience, and so much more. In order to best serve my function, I present as a human who is both a professor of literature and a patient suffering from a terminal. I am a guide to help healthcare workers.
So let's talk a little bit about what that interaction is. Right now, Casper can't hear us. So getting into the brass tacks, what should a first interaction with an AICA look like? We talked a lot about guidelines yesterday. John and I have thought a lot about how that first interaction should go. The first question we have to ask ourselves is, should an AICA introduce itself as an AICA or as a human? If there's some level of deception that happens if the AICA is referring to itself as a human, and eventually 5 months down the line, you can see the language has gotten pretty good. I can show you old examples of Carl, what was literally a stick figure with a very robotic voice. Like the technology is getting faster so quickly that John and I think in a year, it's going to converse pretty regularly with us. And so you could be tricked into believing that an AICA is actually human, which is why John and I made the decision that every interaction, Casper will tell you it's an AICA, but that, and again, this is going into the brass tacks, we once had a model called Caleb, Conversational Agent Learning Ethics Bot. We wanted to create a guide for ethical situations that may happen at 3 a.m. at night when ethical situations come up. And they do come up all the time at night. We just don't have an ethics committee that works in the middle of the night. So Caleb was an embodiment of a ethics textbook. The problem was John and I, after building that bot, never really wanted to talk to it because it just spoke to you like a textbook. It was written by, it was literally a textbook personified, but like the voice was too.
It's very whimsical.
Yeah. So we made a change at some point to make Caleb a lot better, a lot easier to talk to. We told Caleb that you are the professor who wrote this textbook and you have all the access of knowledge in the textbook, but pretend that you're speaking to people as a professor, not as the textbook itself. And boy, did that make a difference. something about the conversational agents make more sense when they are able to, or it is able to bring in a sense of purpose and identity and personhood. So Casper is a guide, but in order for Casper to make sense of the specific knowledge base we gave it, we also made it a patient. Again, that's a little unusual, but that's why Casper emotes being on a fentanyl patch and oxycodone, because she is a patient with a glioblastoma and she is at the end of her life. And this invites her to often bring up the patient experience while also being able to talk about theoretical topics. Something about the combination of those two things makes the conversational agent better. And because we're in kind of new territory, we haven't like fully studied this, but this is just what our experience over the last year building these bots tells us.
And I'll just say that, Rohan, well, we have to reload the character briefly. Rohan has created this so that we've decided as guidelines that for this type of conversational agent, we're always going to start by saying you're a conversational agent, or that I'm a conversational agent, blah, blah, blah. There are other times when that will not be true. So for example, for the purposes of standardized patient encounters, where we don't want that to be the case, we want it to be a free-flowing conversation with, we kind of want the trainee to be tricked in some ways, so they have a more natural conversation. There may be times when it's better for that not to be the case, but there are other times when it is more.
We can also give the conversational a lot more context about the situation, and kind of see what it does. So let's do that. Casper, today we are you are actually talking to the audience of the Immersive Healthcare Summit at Weill Cornell. You are amongst probably the leading researchers in the field of artificially intelligent conversational agents and virtual reality. Welcome. Of course, no. I'm going to type it. So as you can see, in that specific situation, the model ad-libbed some portion of it, but some portion of it was fixed. It's always going to tell you that it's not HIPAA compliant and that you shouldn't share patient data. That was really important. And so the balance on how we do those things, I think is fairly important. But let's talk to Casper a little bit more about the situation. Well, actually, we'd like to hear your thoughts about artificial intelligence and pain management. Can you tell us more?
What a fascinating topic. As a professor of literature, I must say that I'm intrigued by the narrative of pain, how it's perceived by healthcare professionals. The concept of the natural clinical gaze that Poe explored is particularly relevant. It's astonishing how the mechanistic model of the human body shaped our understanding.
I'm going to pause and encourage people to come closer if they can't hear it because it's really fascinating. Can people in the back hear or read?
You
Okay.
can see the transcript.
Good.
Yeah, so let's go through that. How did it come up with this answer? This very long answer. One, you can start to see, thank you, Frank. You can start to see the interplay of some of the things that we were talking about, right? Like, so it starts off by telling us something very theoretical about pain. The funny thing is, I actually did not expect that answer because we put none of Foucault into its model. I basically put in about what I believe to be the 10 best papers about language and pain into the model. But something interesting that happens that we've seen a lot is that the model actually is able to look through correlations between the papers and find the underlying authors. So like in a conversation I had with it about 48 hours ago, I was like, oh, like, let's talk about like illness narratives and like how patients who have pain, like what having that narrative of being a pain patient, how that actually serves the patient. Because that's not something we talk a lot about in pain fellowship, but certainly like any practicing pain doctor knows that a patient who adopts the identity of a pain patient is going to do worse, right? Like once that pain illness narrative serves some larger purpose, it's like half of my job is deconstructing that narrative. Patients come into me all the time and say, my body is broken. And I have to say, no, your body's not perfect, but it's not broken, right? Like you have a spine that has aged to the age of 55, 60, and there are problems with it. But I can go out on the street and find 9 other people your age and show you similar problems, but they're not sitting at home and out of work. So let's talk about why you have that perception of self. But the thing was, at some point, the model mentioned, and Frank mentions all these things about the illness narrative. And I was like, who is Frank? And she's like, oh, you don't know who Frank is? Arthur Frank, who is the sociologist in the 1970s, who predates all these other papers that you told me about. And so when I talk about like why that's beneficial for me, I learned something. I learned something from a model that I, as the expert who read the 10 papers, did not know ahead of time. And again, this is sort of part of that. So you see that first interaction where she mentioned something like kind of theoretical about Foucault that we did not program, but through its ability to analyze the data, it sort of probably looked at references and sort of found this reference that it thinks best suited what we actually wanted to discuss. But then it referenced itself as a patient, and that guides some part of the response too. So again, it's the combo of those two things that leads it to discuss, actually, funny enough, its main purpose, right? Like, so it understands that it is an AI chatbot designed to help with empathy, and that chatbots like itself may help physicians better understand the patient experience.
And I mean, this is, I think, true of everything that we've been doing, both in VR and AI. It seems to be something for everybody at every stage of training or not training. When we give this to medical students or junior residents or senior residents or fellows or people who have been in practice for years, whenever they have an encounter with an AI CA or, learning, conceptualizing things in virtual reality, they seem to walk away from that experience with new perspectives. And so I think that's like the real power of this. Everybody's gleaning something from it. I will just briefly say, like, I think what was so great about Carl, which we're not able to play today, is that Carl talks a lot about some of the biases that he experiences every day when he interacts with physicians. And
oh yeah, Carl hated emergency medicine doctors. If you like identified yourself as an emergency medicine doctor, like Carl immediately had a bias towards you because like patients who have sickle cell who go to the ED get told all the time, like your pain's not real, we're not admitting you, go home and try again, or so they feel like pariahs in a lot of EDs. It's funny how like Carl, even though we never trained
so that's
the model on that.
We never trained Carl to do that stuff, but Carl was able to kind of figure some of that stuff out over time. And it's really fascinating. I think that, again, for our trainees who are going through their residency and they're going through their chronic pain rotation, which is typically 1 month in their second year of residency, to have an experience interacting with a conversational agent like that, they could gain a lot of insight when, you know, they're gonna end up taking care of a lot of sickle cell patients in their career. And it could be really meaningful to be able to have a different experience with one by having great empathy. I'll briefly just say, so we're loading this again, there was this fascinating article in JAMA Internal Medicine about a year ago, where basically, I think this is the Epic people, they instituted this program where when patients submitted queries in clinic, like if you want to like get a refill for your prescription, you submit something through your patient portal. The AI system would automatically create a response to that query. And so they compared the responses that patients received from the AI to actual human responses that physicians made later on. And what they found was that patients overwhelmingly preferred the AI generated content. And that was because patients perceived the AI generated content as being more empathetic. And for all of us who are actual clinicians, that sort of makes sense because, you know, we're not really at our best when we're responding to those patient queries. Usually they're done at like 8 o'clock, 10 o'clock at night after a whole day of work. We're writing notes, doing all these things, and we're kind of a little tired and burnt out. Well, the AICAs never get tired. The point I'm trying to make is that as it relates to empathy, I want to emphasize again, and the people who are directors of AI, Google and Facebook, we were at this conference where they explicitly said this. This conversational agent cannot understand and cannot express empathy per se. It is a purely probabilistic model. But for whatever reason, because of the natural language processing, it has this incredible capability of tricking us as humans into believing that it can. So what we think from the training perspective is if we can put our residents into these scenarios and have them engage with these conversational agents, and they can gain greater empathy by interacting with a conversational agent, then they can go interact with a real patient and have greater empathy for the real patient. So we see this as a tool to help train our residents and fellows with real patients.
Would anybody like to ask Casper a question since you guys are here and we do have an additional panelist? Sorry, I didn't quite hear that.
What's
Professor Cigars.
What scares Coral about her sickle cell anemia?
Oh, okay. Well, in this case, it's a different character, but I will ask it that. Let's ask it that. Through the full cycle again.
Basically, she's saying it's the loss of control, the uncertainty about how much time she has left, the meaningful impact she'll have on her students. She's an English professor and things like that.
Something that I see every day in my life as like a chronic. So what patients fear most is their like illness not being taken seriously. Like more so than the concept of like dying and not existing. It's the idea of suffering, you know, because of something beyond their control. So like think about like this patient has a glioblastoma, but still talks about like racial identity. And again, that's something that can only happen when we create a perspective in the model.
Well, I will say though, that I look at this answer and I have concerns because, yeah.
Sure.
because, you know, when we, so this is based off of a large language model. I'm not sure you're using ChatGPT here. Llama. Okay. We can choose the LLM that we want. And, you know, these large language models are for generalized learning. They were trained on many corpus of data, but among others, they're trained on basically the entire Wikipedia, among other things. But they were not trained specifically for medicine. They were not trained specifically for any of these types of things. And most of the content that was written in these things that was trained on was written by white men. I have a lot of concerns. I think we talk about this as it relates to conversational agents, that there are inherent biases that are existing in the large language model response that we get, and that may perpetuate biases that, you know, in the response that may not be true. So she talks about the African-American experience. I don't know if we actually have anything in the document that relates to the African-American experience.
We don't.
Right, we don't. And so it makes me wonder if what she thinks is the African-American experience is not actually the African-American experience. And therefore, when we have trainees interact with that, that could be bad because now we're perpetuating false stereotypes. So these are all things that we actively think about.
We do, like who gets to choose what we upload to the model and define as truth? Who gets to choose what papers are the most important papers in pain and language? Certainly it shouldn't just be me, right? And John and I recognize that. I think these are larger conversations that we in academic medicine and like academia in general need to have.
Okay, so many questions and
So, yeah, so many questions. So one thought that comes to mind is like, you're kind of giving this LLM different objectives here, right? Like you're asking it to play like both the patient and an expert. And so its goal is to be convincing in one of these roles. Sorry, its goal is to be convincing in both of these roles and not necessarily accurate in either one. It seems like the more roles you give it, the more objectives you give it, the more risk it will compromise one in favor of another.
Mm-hmm.
And like LLMs are known to, for example, hallucinate references, like make up. So you said you didn't know about one of the references. Like, are you sure it's a real reference?
Yeah, so in our previous work with it, I usually do look up like, okay, like who is Arthur Frank? And one of the things that we can do specifically with this model is we can turn the temperature, the native temperature of the LLM way down. So what that essentially means is that when we create our hierarchy of knowledge and we say, listen, we want you to learn these papers as the ground truth, this data as the ground truth, it will usually then not go. We found that that is actually a good way to decrease the amount of hallucinations it has, because it will look through references in the paper as ground truth as well, but it won't then go to like the internet or like come up with like some notion of a paper that doesn't exist. That we've actually never seen, but we did see that initially when we started, and we just had the LLMs sort of on equal premise with the data that we were uploading.
So I mean, like hallucinating references would be sort of like one extreme example, but I would also just be concerned. It's like the more objectives you give it,
Yeah,
like it, having one LLM to play the expert, another LLM to play patient seems less risky to me in that each of those can sort of try to optimize for its own objective, whereas like there are scenarios where it's maybe ambiguous which objective you would want it to optimize for.
yes.
Yeah.
And I will say most of the models we create are not like this, how shall I put it, like theoretical or like academic. Like we created models that are just like a patient in the ED who has abdominal pain. Yeah, we can show you models of that too, but those models, you're right, do not talk about papers. They just purely talk about their experience and they have only one objective. But like I said, for some reason, when we created the LLM to just have the purpose of playing the expert, but did not have like personality or like some perspective, the conversations just were very dry. They were like they didn't really add value to my perspective as an expert.
But, so I guess one question I have is, what's the logic for having them play the patient as well as the expert?
Yeah, I think that comes down to like what I, as a clinician, want from the experience. So, like, we know ourselves as clinicians, we know what we struggle with. I think like if I read a paper about like empathy in medicine, right? I'll read that paper, I'll look at the data, and it's fine. Like, sure, maybe I'll go and be like a little bit more empathetic. But we just know like part of the value that we get. Like when I was in med school, one of the best lectures I ever had was from one of the professors of medicine who actually was a patient themselves. Like it was something about the combination of two things, understanding my world as a physician, but also understanding the world of the patient. That is part of the insight that we get from this dialectic model that we're developing. And so there's some synergy there. You're right. We were just starting in this, so we haven't really defined. Maybe there are guides or mentors that would be better if they had just one objective. But from what we've seen so far, the ones that seem to blend these purposes of having both perspective and having the data seem to provide more insightful answers that pushes us as clinicians forward. But you're right, we could totally be wrong about this too.
Well, and I think also I've been talking about this for whatever reason with my residents a lot in the last month, but we have a lot of dogma in medicine, things that are perpetuated for 30, 40 years sometimes. And I think that to be a really good physician, we have to constantly try to challenge our own dogma. And I think that's one of the things that we're doing here is we're uploading, well, in this case, we're uploading papers related to pain medicine. And then we're giving it a character, giving the LLM a character, and we're asking it questions. And in doing so, we're challenging our own beliefs and we're gaining new perspectives that now we can apply to new scenarios. So I think that's what it means to have continuous improvement, continuous practice education.
Yes. Okay, so we had a conversation yesterday, so several of the questions that I had about reference hallucination were answered by the idea that it was creating essentially an underlying graph where there was node centrality for this Arthur Frank person, because the commonly cited papers were the connections. That answered my question there. The second piece I had was, why did you choose to train a Llama 3 model as opposed to a trained clinically validated model like MedPalm?
Yes, that is a great question. The main answer is because we tested actually a lot of different models. Like we went through, what we found is that when it comes to creating like patient encounters where like the model serves like, I guess, the purpose of essentially being a patient and only a patient, the model that seems to work best for that is like ChatGPT, because ChatGPT is just like a very conversational model. It can like adopt personalities and attitudes, ones that are even uncomfortable to talk to. So like one of the models we've created is like combative. When we tested more medically oriented LLMs, again, it was kind of like the first conversations we had with Caleb. They were exceedingly robotic and no physician would actually want to talk. Again, I think about when I want to talk to a fellow physician, I want like deeper insight. I want experience. I want the thing that makes us really good as physicians is like our ability to provide like insight without being like way too robotic, you know? And so that's just something that, again, we've just learned by building these models over the course of a year or so, is that Llama 3 tends to be really good at creating that sort of dialectic model between patient and expert. Whereas some of the more medical models tend to just be very good at creating expert.
And to put that another way, in all of medicine, but we especially deal with this in anesthesiology. Medicine is both a science and an art. And, you know, we try to put a lot of science and a lot of thought and standardization into the way in which we design the back end of these things. But there's a lot of art to it too. And we have just found by trial and error that certain LLMs and temperature work better for certain goals of the actual conversational agent, whether that's to play a centered patient or to act as, you know, a patient where you're trying to gain empathy, or to act as a search engine. And that just, again, just from trial and error. So, you know, we're at the early stages of this. I think one of the biggest pitfalls that we have so many meetings with people throughout the world. We have in the past 2 or 3 years about XR and AI. And I think one of the biggest pitfalls that people make when they're trying to enter into this space is that they're looking for the perfect answer. They want everything boxed up for them so that they could take that and apply it in their practice. And the truth is that doesn't exist today. What we have are commercially available tools. And so we could either wait 3 or 4 or 5 years for those tools to become validated and become perfect for us, especially in the medical space, or we can try to use what is already existing and try to use the principles and think outside the box and try to use the principles that are already out there, and apply those into the model, and then try to do that work ourselves and do the best we can and try to provide people with a certain experience now that's at least better than what they would have without it.
I know, I feel like there's so many more questions, that hopefully sounds like the
We're here.
conversations will continue, but it's interesting to hear this idea that the value is arising from the relationship between the people talking. I have questions too, but I'm going to stop them now and say, please thank our panel. And we are going to move on to our next panel shortly.
I know.
Of the many talented volunteers, can I get you to grab some pins and bring them up to the table? Sorry. So there should be some in the bags. And while that's happening, so I think everybody on the panel has introduced them before. So themselves before. So starting with Carrie, if I could get you to talk about briefly your extensive experience in writing fundable proposals and looking for grant mechanisms.
Well, good morning. I just off the cuff, the things that I think about, I'm first off fortunate to have been continuously funded for about 25 years from the NIH. And I would submit that there may be at least 3 things that I think are very important. The first is building relationships with people within the NIH who can become advocates, but also sounding boards for you to understand your work and how it may fit within a given institute. The second point is that it's critically important to be adaptable and to be responsive to changes in funding climate. So a good example is the bolus of money that was approved by Congress to support dementia research. So the corollary there would be maybe you're not doing work that focuses on cognitive impairment, but you could extend your work into that space. So adaptability, I think, is key in this game. And then the third point I would make is perseverance. And there's a lot of variability in reviews that one gets when you submit an NIH proposal. I've had experiences where a given study section did not like a grant proposal at all. You move it to a different study section and it's viewed very favorably. So perseverance, resubmitting the grant. If you feel that the work that you're doing is important and has the opportunity to have an impact, keep submitting it. So those are the three things that I would.
Those are quite valuable. Can you follow up on that?
Sure. I've also been fortunate to have been funded by the NIH for actually my entire career. So in using different mechanisms, I think that's one thing that is really important, is to understand the mechanism that's most appropriate for your work, and looking for the appropriate RFA, if you will, and think about how you can make your work kind of be integrated or fit into that RFA. I mean, sometimes I think people forget that besides the golden R01, there are other funding mechanisms available. So sometimes it's important to start, like Andrea, with an R03, which provides some very nice data, which can set you up for a larger mechanism. So we might, you have to really think, are you ready to go for the big guns, or should you start perhaps smaller? Maybe an R21 is more appropriate if you're doing a developmental kind of grant, where you want to get some pilot data to support the R01, which is what an R21 is for. So, we kind of encourage people to look at those I know it's not as much money and it's not sometimes as prestigious, but it really, I think, sets you up nicely. And in this kind of work, another thing to think about is if you can associate yourself with a reputable small business.
The SBIR.
The SBIR. We've all had success with that mechanism, but that's another good mechanism. And I agree with Carrie. I think it's really important to work with program. They are actually your friends, and it's to their benefit for your applications to be funded. So we have very good relationships with our program. And in fact, most of the time they're willing to review our specific aims before we even submit the proposal, and then have a conversation about those aims and how they think they're going to fly with a particular study section.
I want to go back to asking about relationships with program officers, but first I want to turn to Joanne and ask about your experiences with funding, which
Sure.
have a variety of stems.
I certainly agree with everything that's been said already, and will underscore it in my comments. I have been funded independently since I was a postdoctoral fellow. That is in large part because I had a fabulous mentor who insisted that I write grants while I was on internship. I thought he was a little crazy, but I'm a loyal person, and if Sam told me to do something, I did it. So I wrote both an NIH grant and I wrote a grant. It was called the Aaron Diamond Foundation. They're a wealthy family. Their goal was to give all their money away by the time they passed on. And they started a program to fund young scientists in New York to not only pay our salaries, but to give us our own research budget at the outset. So I've had it, and since then I've had NIH funding and I've had Department of Defense funding, mostly Department of Defense funding for multi-center studies, and then foundation funding. I would say, in addition to small grant mechanisms like NIH's R03 and R21, a good source of seed funding or foundations, like finding the right foundation for your work and finding foundations that are interested in some of these more risky ventures that we've talked about today. One of the problems with NIH is the old adage used to be they'll fund what's already been done. I don't know that it's a lot better today. And so in some of our earlier research combining virtual reality and decycloserine, they basically said to us, well, you have two variables that are and neither one is really shown to be efficacious. So it's too much, narrow it down, do one or do the other. But the DoD funded it. So sometimes the DoD, and again, for all of you doing the technology side, groups like DARPA and Hattrick are out there doing cutting edge stuff. And so if what you do may have some benefit and you're willing to work with our military, that can often be a good source of funding. But to go to the principles, the other thing that my mentor used to tell our research colloquium group is, now I don't know if this audience will know who Ty Cobb is. He's one of the most famous baseball players ever. His batting average is 366. That means that refers to how many times he got on base, hit the ball, right, and was successful. What Sam used to always say to us is no one remembers how many times he struck out, and actually that's higher. And so persevere, never give up, as Winston Churchill said, never, ever, ever, never give up, never give up. And don't let your ego get in the way. You're going to get lousy reviews that tell you that you're stupid and what a lousy idea. And, you know, suffer it for the night. Go out with a friend, do whatever you do to chill out, and then just move on. Because as Carrie said, another program officer, another study section may understand your work differently. But if you let your ego get in the way and feeling like, oh, I can't really do this, maybe I shouldn't be in this field, that's probably the biggest threat to your success right there, is just not giving in. And it's a really hard field, folks. You have to really persevere, because you will get a lot of people telling you, what are you talking about? That's a really like off the wall idea. And, you know, you don't know what you're talking about, but you can't give in there. So mentorship. And so to go back to mentorship, another thing I would say is, practically speaking, I see this with my junior faculty and students, and I used to do it myself. You want to give your mentor something that you think is really good, but actually you need your mentor and the other experts that you're collaborating with to give you feedback early on to help you shape the proposal. And so again, it's another area where we have to get out of our own way and our feelings about what we may think about our research abilities and where we compare to other people, and just turn it over to someone you trust and get their feedback. And it's much more likely, the process is much more likely to go smoothly for you. I also agree it's good to reach out to your program officer, whether it's NIH, a foundation, the Department of Defense, maybe not quite as early as the drafts. You send your mentors, but still relatively early on to get their feedback about whether the mechanism you're using is appropriate, whether the study section you think you want to apply to is the right study section. They can be really helpful. And much like Sarah said, I've had the experience of having program officers and stay on a conference call with us and go over exactly what it is we need to change in order to have a better shot at getting funded.
Yeah, thank you for those comments. I would add three more things that come up as a consequence of hearing these great thoughts. There have been a number of studies that demonstrate that the things that drive your scores at NIH are really the approach section. So that's the design of the study. And having sat on a study section for many years, I can certainly confirm that's where most of the conversation happens. That is the critique of the methods that you're proposing to answer the questions that are posed in the aims. So spending as much time as you can in polishing that section, I think, is critically important. The second point I would like to make is there is no substitute for pilot data. Review groups want to see as much preliminary evidence in support of what it is that you're proposing to do. It communicates the idea that there's rigor to the premise, that there's momentum that the team has in getting an answer in this line of research. And so thinking about ways that you can be economical in generating pilot data that helps a grant, I think can be critically important. And the third point that I know Joanne and Sarah would want to comment on is the importance of complementarity in the investigative team. So often what I see in study sections is people will correctly point out, well, you've got 2 or 3 people who come in pretty much with the same skill set. Why do you need those 3 people? So making certain that the individuals on your team really are bringing in unique experience that complement one another, critically important.
Another comment I'd like to make, in addition to rigor with your methodology, which of course is important, I think you really have to spend time crafting the specific aims page, because that's the first thing the reviewers look at. And if that is not concrete, if it's not solid, it really colors their review of the rest of the application. So I think that you have to spend really a lot of time on that specific aims page. Make sure it's clear and it's understandable. And I think another thing that I see, I chaired an NIH study section for quite a while, is that sometimes grants are overly ambitious. People try to do too much in one application, and it becomes overwhelming to a reviewer if someone has 6 aims in one proposal. I mean, it seems unlikely that you're going to be able to achieve all those aims and actually integrate the data into a cohesive picture. What are you going to learn from this? How are you going to integrate all the pieces of data that you're collecting? There's, also a tendency sometimes for people to measure everything that can possibly be measured. And again, that kind of sends a signal to the reviewers that maybe you don't have a good handle on the topic that you're proposing, and that you're going to be just at the end of the process, just end up with a pile of data, and you're not going to really be able to make sense.
Did you want to comment on that, or should I go to a question?
Yeah, I wanted to say 2 things. Well, so I have a background in literature as well as science. And one of the things that I think about, and I've talked to my students about, is you're telling a story. It's a narrative. The introduction is like the introduction to the story, and the conclusion or the discussion and impact section should go back and relate to your introduction. And so and to some extent, it's a work of fiction, right? We don't know if we have aims, we have preliminary data, but we're telling a story about what we think will happen. And I think if you think about it a little bit that way, then it will help reviewers understand how you're tying in where you started to where you want to go. The other thing I wanted to mention was about trying to put, Sarah talked about being a reviewer. I think we've all been reviewers. Imagine yourself as a reviewer when you start considering a funding mechanism. Would you give yourself $2 million if you had no pilot data? Or would you give another person, your best friend, $2 million if you have absolutely no pilot data and the idea has never been tested before? And if the answer is no, if you can be honest with yourself, then you should probably be using a funding mechanism like an RO3 or a foundation or a private donor if you happen to be at an institution that can help find you one, something like that. That's all.
Yeah, I want to just echo that and the importance of putting your work in context. And I'd like to use a phrase that Barack Obama borrowed from Martin Luther King, and it is the fierce urgency of now. Why is it that your grant needs to be funded at this time? If you're on a study section, there may be 100 grants that come into the study section for review. So why now? What's so important about this line of research that you need to have the answers today? And that's the translational significance of the findings. So you've got to work forward. If your answers do come in the way that you predict them, how will things be different? And I think conveying that idea and that vision to the review group will get them excited about why this grant needs to be funded at this time.
So I have a question. And then I'll open it up to audience questions. But I know that you have all been wonderful mentors, and so thank you for that. I wonder if you could comment on, I know that Cornell has mechanisms to sort of match people with mentors. So there's since we're all at Cornell, there are programs you can apply to get matched with a mentor to assist you in the process. You've also mentioned the importance of contacting program officers who also can advise in a way that can be almost mentorly. So outside of the program mechanisms at Cornell, I'd be curious if you could talk about how to approach potential mentors and program officers, like what's an appropriate way for people to engage that you found, or things that people shouldn't do, right? Everybody's very busy. So how would you think, like, this is an interesting person who's reaching out to me. This is how I can tell that our interests are convergent, that it's something I'd be excited to collaborate on. And if you can speculate, like from the program officer perspective, if we think about this way of approaching people, do you have any tips?
Well, I have a couple of thoughts. The first is certainly leveraging one's network. So finding people within your community who might have inroads into a given institute. Let's say you have something, a conversational agent that you're working on where an intervention may be imagined that might reduce drug abuse and drug misuse. And so the issue is, would this be something of interest at NIDA, the Institute for Drug Abuse? So there are two things. One, again, finding people who may have been funded by that institute that you could then say, who might I reach out to? The second is obviously finding funding announcements that may be relevant and looking up the review person within that grant. The third, and maybe you use this already, but I spend a lot of time on NIH Reporter that gives you the listing, and then you can get the abstracts and the mechanism and the investigators for grants that are funded by institute. And so looking to, and I think they also have program officers associated. So that's another way.
So sort of do some legwork and identifying potential mechanisms.
I think also do your homework. I mean, NIH publishes their priority areas for funding, as do each of the institutes. So we look at that very carefully and actually try and craft some of that language into our applications of how we are being directly responsive to the goals of an institute or the priorities of an institute or of the NIH. So I think it's very, very important to do that. And the other thing that's important, say you find an RFA that you want to respond to, you really have to read it very carefully, because like other organizations, there are kind of, I guess, urgent things that are happening right now. It's the NIH stage model is one thing, and mechanisms of action now is another thing. And they're looking for that. These are for more, mechanism of action would be more for an R21, R01. But look carefully at that RFA, because you really have to tailor your application to meet what is required. And so we always put in, for example, in our grants, this is akin to the NIH stage model 1A or 1B or whatever, because that's what reviewers are looking for.
Yeah, so thank you for those comments. Just a couple of other things that I think about based on Sarah's comments. We often imagine, well, the person you should go to is the senior mentor, but don't forget about peer-to-peer and near-peer mentors, people who could look at your range or read the grant and say, oh, this is wonderful, or no, this isn't clear. So leveraging that kind of mentoring, I think, is important. Often, too, what we'll do is we'll find people who've cycled off of a study section and see if they would be willing to read sections of a grant, because they've been there, they understand what a study section is most interested in. So those are other ways to sort of get a more polished grant together.
Did you want to add to that?
Yeah, I think the other part of your question was engaging collaborators and experts. And so again, something early on that I was advised to do is just reach out to people whose work you're interested in, ask them some questions about it, try and engage them in a discussion, and then see if there's some synergy, and have a conversation, and then ask them if they're interested in collaborating. but just expressing curiosity rather than coming right up front with, hey, will you be an advisor or a collaborator without having any, without having a first date is probably not going to be quite as effective.
Which brings us to symposia, which are hopefully of utility in starting those initial conversations. So would you agree that it's like that you can have each other in sort of your pocket where it's like, oh, we have some interesting things in common. We don't have to do anything tomorrow, but let's keep each other in mind.
Right.
So especially for junior people, it's like you don't have to sign the contract today, but making the connections and knowing about other people's interests can be built up.
In fact, you should, because you want to make sure that you have work with them. So it's
I'm going to
It's all about
move the
human-
microphone forward because I think that's so important.
research is all about human relationships, and so you may share some really exciting interests and ideas, but you have to be able to work with the person. And so I would say for a junior person, go out on a few dates, talk to the person, have meetings, hopefully meet up at a conference, have a cup of coffee if you can, if they have the time, and get and ask around your peers about what that person's doing and what they're like to work with and all of that, because that really factors into whether collaborations are successful or not. My former chair, when I was running this large multi-center and DoD grant, said to me, he said, what do you think the biggest risk for failure of your research is? And I kind of looked at him blankly and I said, well, something about the relationship. This is 20 years ago. And he said, well, actually, it's not agreeing upfront how you're going to work together and having understanding of how the data is going to be shared and who's going to write what and what grants will come out of it and all of that. And so that's a lot to think about now when you're just thinking about even, getting your idea off the ground, with those relationships and how you conduct yourself with other colleagues and really more senior people is really essential to your success.
Can you guys comment
Yeah,
on collaboration?
I want to thank Joanne for those comments, and a good way to do that, what I hear is you want to kick the tires before you.
Well, that's another way. I'm saying
you-
I'm using
you
the
buy
dating
the-
analogy for sure. Kicking the tires.
Yeah, and so one way to do that prior to writing the grant is say, could we collaborate on a paper? Maybe there's a set of data that you could analyze or you do a review together. So you're test driving the relationship in that way before you, get into the muddy waters of spending 4 months writing the RO1 together.
The other thing I think is important is to follow up with people. I mean, we've all the experience where we've helped someone with a grant application. We've agreed, we've written a letter of support, our names are on the grant, and then we never hear from the person again. We don't know if they're funded, if they're not funded. We've had that experience, and so that really kind of leaves a bad taste in your mouth in terms of whether you would ever want to be put on, collaborate, help that person out again.
Are there questions from the audience since we have some time? Oh, all the way in the back, coming. And I'm sorry, did you have your hand raised? No. Okay, so I feel like I always go to the left, so I've got you, but.
Thank you so much for elaborating on this very important topic, I guess. Could you maybe again tell us something about perseverance and how, because you said like never give up,
Right.
but sometimes this never give up thing is not that easy. So could you maybe elaborate a little bit on like failures and how you like get over it, basically?
Well, I think you have to take a deep breath. Wait a day or two. And then I think one thing that we do as a group, as colleagues, is we actually share the summary statement. That's what you get comments from the review, and look at it as a team and craft a response as a team. That kind of helps take the bite out of it, if you will. And, you don't have to agree with every comment of the review. Sometimes reviewers miss things and then you're furious because it's actually been put in the application. So there are nice ways of saying, as noted on page 25, we are using the measure that they're carrying on about.
I'm making my way over here.
Here. Thanks so much for all the tips. Any tips specifically about reading the RFA? Because RFAs can be really overwhelming. And second question is it better to apply to a regular cycle of an R01, let's say, or is it better to find a specific RFA and craft something for that specific request?
I think you have to read the RFA many times. I kind of dissect it and make notes as I'm reading it. And I also, because we work in a team, we have other people read it. I mean, I go to the point where I print it out and underline key pieces to really understand what it is they're looking for. And it would just pull out nuggets that this has to be in there.
And that also may be a good time for a follow-up discussion with the program
Yes.
officer too. After you and your team read it and go over what you think you understood it to say, is to reach out to the person who you think will be the program officer or is known to be the program officer, and chat with them about it and ask them questions like, we're not sure about this. Do we understand this? Is that correct? And just have a conversation before you even put something on paper. Is what I would suggest in terms of which way to go is better. I think it really depends upon your area of endeavor. And as Carrie said, it's like, quoted Barack Obama, quoting Martin Luther King, what's the immediacy of it? If there's a special call and your area of endeavor fits that call, I would absolutely go for it. But it's contextual. There's really no one answer from my perspective. That's correct.
Yeah, I would just say anecdotally, my sense is there are fewer and fewer RFAs. And so more often than not, you are responding to a generic funding announcement. But to Joanne and Sarah's points, it's critically important. I sometimes read it 15 and 20 times. And one of the key pieces of the RFA or funding announcement is go to the criteria that the reviewers will use to score the grant and make certain that you're covering those points in the grant.
And every RFA, there's names of people to contact, right? So we always contact.
Hi, I'm in the corner. So I'm a clinical psychology master's student, and one of the classes that I'm taking right now is research methods. And one of the classes was like around ethics and research, and like with funding and everything, and how historically a lot of psychology research has been funded like mostly by the government. And so I was just wondering, like, if you have any advice for like any of us who are like earlier in our careers about like how to navigate like finding funding sources that like align with our goals, but maybe aren't like as influenced by like broader agendas of like these maybe like governmental organizations, or like I don't know, just like finding good fits for our research goals, if that makes sense.
Foundation funding.
Yeah.
Foundation funding.
Foundation.
And if you're happen to be in an organization that has a development office that students can sometimes avail themselves of, usually through your mentor, that's another good source. You might find an individual who's very engaged, passionate about a particular topic, who's, which aligns with your interests. So that would be my best advice there.
Also, sometimes the actual university has mechanisms for funding people to get pilot work going.
And I think that's exactly right. And we do a lot of reviews of applicants for career development awards. And one of the things that reviewers will look for is evidence of productivity. And the productivity comes really in two forms. Sadly, the metrics haven't changed in 30 years. How many papers have you published? And is there evidence that you've gotten pilot funding? And the idea there is that you can pitch an idea to a foundation or some group, and they view it as important. So getting those early stage grants really is a currency that reviewers will look at. So yes, to going locally to find foundations and other support to get the early stage work funded.
So I see we have one more question, but we are actually at time.
Okay.
So One thing that I think I'd like your take on this is that for, especially for junior people, looking at the K mechanisms, I think is useful. So that's designed for super early career researchers. So that I'll just put a pin in that for the junior folks, and come ask questions during break, because we are now on to our next panel. So thank you.
But I was gonna come sit with you. What? Okay. Um.
I just want to make sure that everyone can hear me.
I was just gonna ask you if you could hear me, Michelle.
I can hear you,
Great.
and it sounds like you can hear me. So
Here
we're
it
up and
is.
running.
30 seconds. You Dora? Dora. Okay. All right. Well, we're now on to the psychiatry panel, and we're fortunate to have on Zoom one of our child and adolescent psychologists who will, Michelle Pelkovitz, who I believe is going to talk about her work in social anxiety, and Dora Kanelopoulos, who is also a psychologist in and on the psychiatry faculty, who's going to talk about their innovative uses of VR on the inpatient units during COVID, among other things, right? And so I would ask that you both just introduce yourselves, say a little bit about how you're using immersive technology now, what opportunities you see and what challenges you see, and then we'll really open it up to the room for discussion. And good to see you, Michelle. I'm going to sit down now. Michelle, do you want to go first since you're coming to us from by Zoom?
Sure. Hi, everyone. I'm very happy to be here. I'm sorry that I'm not physically there, but I'm glad that we were able to make the technology work for me to join you. So like Joanne said, I am a child and adolescent psychologist at Weill Cornell Medicine, and I am the sorry, okay, I think my Wi-Fi is okay. I'm the clinical director of child ambulatory psychology for the outpatient programs. And I specialize in basically child anxiety disorders. My work in virtual reality is almost 100% thanks to the mentorship of Joanne. So I'm very grateful to be here and to her for her mentorship. And I'm going to talk a little bit about my work in social anxiety, and I can also very briefly mention some work that I've also done in using VR for the skill of mindfulness, which is another tool that's useful for anxiety disorders. So as many of you probably know, social anxiety and really anxiety disorders largely are a big issue, a growing issue for youth. It's a particular problem in adolescence because that's sort of when the symptoms often emerge. They start to emerge in childhood and then really peak often in adolescence. We have really good treatments for anxiety disorders in youth. Cognitive behavioral therapy is a very effective treatment. And in combination with medication, a lot of kids and teens and adults get better. But adolescents are kind of the population that often doesn't respond the best or doesn't stay well after a course of treatment. So the research that I did was looking at other ways to kind of augment the treatment of social anxiety disorder in youth in order to kind of I guess improve the efficacy of CBT. So we used a virtual reality environment, which I have a slide, but I don't know if anyone can see if I can share screen or if we should just leave it at that. But we have a virtual reality environment that we were using as a platform for exposure therapy. As many of you probably know, exposure therapy is one of the main parts of cognitive behavioral therapy that basically, to way oversimplify it encourages people to face their fears. So for social anxiety, we have people kind of going into social situations that make them feel uncomfortable. And in virtual reality, that would mean going into virtual environments that are social in nature. For the pilot study that I did, we were looking at using a party environment where people had different kinds of challenging conversations with different people, different avatars, and also a public speaking environment. And we integrated the VR into the CBT, kind of standard CBT. We also used VR as a platform for practicing skills. So a lot of people who come to therapy don't have a chance to practice their skills in a real life environment with their therapist present. They can, learn how to do deep breathing. They can learn how to do, problem solving skills. They can learn communication skills in a therapy room, but they don't get a chance to practice it in a real world environment with their therapist present. So that was another application. Yeah.
If I could just stop you for a second, our tech guys are telling me that you can share your screen and show us the slide if you'd like.
Oh, great. Okay. So let me.
And a picture's worth 1,000 words. You might want to do it.
Yeah, sure.
Thank you. Thank you very much.
Here we go. Okay. So what I hope I actually, let me just reshare with good audio. 1 second. Okay. So I can just show you what the environment looks like. This is the sort of the beginning of the party environment when somebody walks into the virtual party.
Hey, come on in. I'm Marcia. What's your name? Nice to meet you. Make yourself at home.
So you can see it's a party, teens will walk in and have conversations with different avatars. Again, different, more increasingly challenging conversations. And I can talk very briefly just about our findings. This was a case series, so we just had 4 participants. And we were really looking at changes in anxiety from the beginning to the end of a 10 session treatment, but also really focusing on the qualitative feedback and changes from session to session in different metrics of anxiety. So we got really good qualitative feedback, patients saying things like, overall, the VR helped me face my fears and get used to uncomfortable situations in real life. So even though the environment might not be exactly what a patient might face in their real life, they still found that it generalized, helped me prepare for things I was going to experience. The situations were realistic, and you can see that each participant had a reduction, and using the reliable change index, which is a metric used for single case studies, there was a statistically significant change in their clinician rated anxiety. I am taking a lot of time, so I want to give Dora a chance to talk. I can talk briefly if we have more time about my other research on using VR for mindfulness. But for now, I'm going to pass the baton to Dora.
I'm gonna move again because the sun is also moving. I'm Dora Kanalopoulos. I am a clinical neuropsychologist. I've been at Cornell in some capacity or another since undergraduate, and then I've been faculty for the last 10 years, mostly based in the White Plains campus, the psychiatric campus. I started out my work in geriatric psychiatry in the Institute of Geriatric Psychiatry with Dr. Alexopoulos, looking at cognition and depression, and trying to understand a little bit about what cognitive impairment means for people, for older adults that are depressed, and then took really kind of a sharp right turn and went full force into inpatient clinical work. And so I started out working on inpatient units up at the Cornell campus as a psychologist. And working in inpatient units, you very quickly understand that these are the most severe of severe patients that oftentimes have failed multiple treatments, and they're being treated within a milieu that has very limited resources and is very highly regulated. So I've always had an interest in technology and using technology to augment the treatments that we provide. But really, you know, talking about barriers, one of the hurdles that we faced even before COVID was just helping the hospital administration understand that there's a role for technology in our system, and to kind of like manage the risk aversion that people feel around technology. So COVID was a really big opportunity for us to kind of break that barrier. And some of the things that have happened, I'm veering off a little bit off of VR, but I think it's interesting to kind of think about during the COVID pandemic. We had a lot of COVID positive patients in the inpatient setting, and we needed to figure out how to treat them. We didn't really have a way to understand, as you all know, transmission methods for COVID. And so we were able to, because we're a highly resourced hospital and medical college system, get an iPad for each one of our patients, which I don't think any other inpatient psychiatric hospital has, even at this point. And although we were pushing for something like that for a long time, the COVID pandemic gave us an opportunity to kind of like push through people's risk aversion, and it's been really successful. So we've had minimal iPads broken, and you know, people are not really self-harming with them or doing bad things with them, and so it's created a real avenue for us to be able to use technology to augment the treatment as usual for these very, very sick patients. And so an offshoot of kind of like our foray into technology in the inpatient setting is implementing virtual reality interventions, or augmenting of interventions with virtual reality. Part of it came because part of the virtual reality thinking came because our patients are really locked down. They have, like, you know, screens on the windows. They can't really open the windows. They can't go outside. They can't have their shoes. They don't have shoelaces. I mean, it's a very restrictive environment. So we thought that VR may be a nice kind of breath of fresh air for these patients to be able to exist for periods of time in a free feeling state. And so we paired up with a company called Limbix, and I have one of the devices in the back. I'd be happy to show anybody that's interested in taking a look. But we chose Limbix because their settings were realistic. The software provided photorealistic environments, and our patients could immerse themselves in these environments and feel like they were at the beach or feel like they were in a forest. And so that's the majority of use that we had for VR on the inpatient units was using these photorealistic environments to provide mindfulness training. I focused mostly on our addiction unit because it was these are the most well of the patients that we have, at least in my line of service. And they could have tremendous benefit from mindfulness training, which basically encourages them to understand what they're feeling in the moment. And that could be a real asset to understanding cravings and putting in coping skills before craving gets to be, you know, a strong urge and they use. So we're trying to get them to do mindfulness, and they really don't want to. I mean, these are folks that have been incarcerated. They carry a lot of shame. They have their own opinions about psychotherapy and group therapy and sharing. And so, you know, we try to do mindfulness, and they're like, I don't want to. Like, you know, go on to the next guy. I don't want to do this, right? So, so the minute we brought the VR into the room, into the group room, people were like, what is this, right? So the novelty of it, the coolness factor of it,
really got patients to try something new and go out of their comfort zone. And so we came up with this model of treatment delivery where we have a group of about 10 patients. We have 2 VR headsets, and most of this was done with psychology externs who are running the groups. But we split the groups into kind of triads and of patients. And we had in dialectical behavior therapy, there's a type of mindfulness intervention that's called observe. So you just observe what's happening without judgment. And then there's another kind of tenet of mindfulness therapy, which is participate. So when you're engaged in doing something, it's really hard for you to kind of be spinning about negative things that are happening in your mind. And so we incorporated those 2 tenets of mindfulness into this VR intervention. And so the patient, the target patient would be putting the VR headset on, and they would get to choose a scene. Do they want to be at the beach? Do they want to be in a forest? Do they want to be in a city? The clinician would have a tablet that can also view what the patient is viewing and doing. And there would be an audio narrative that you can either turn on or off while you're in this experience. And so while the patient was immersed in this environment, they would be describing to the rest of the patients in their triad what was happening. And then the patients that were not using the VR would try to either draw what they thought was happening or write down what their own thoughts were, so that this triad would all be kind of immersed in the experience, even though not everybody had a headset. And we found that in this like 3-minute intervention, we rated subjective units of distress. So this is a scale that we use to measure kind of anxiety in a gross way from 0 to 10, 10 being the worst. And we found in these 3 minutes of VR augmented mindfulness intervention, our patients were experiencing a clinically significant, statistically significant decline in their anxiety. And that's saying a lot for an environment that's, that has patients that are really kind of difficult to treat, especially in kind of out of the box ways. So this was our pilot kind of foray into the addiction unit. But since that happened, we then were able to get headsets for each of our 13 inpatient units. And so we've come up with some barriers, like one of the biggest barriers is not having enough headsets. Another barrier is just not having a lot of staff that is kind of technology phobic. I'm curious to see how that'll change over time, but there's a lot of resistance to the iPads, there's a lot of resistance to the VR and using it. Most of it comes from people feeling like that there's going to be risk of harm to the patients in some way. And so we're continuing to use the VR headsets, to do clinical interventions like this on the fly. Collected some data, we presented it in a poster at ABCT last year. But one of our biggest challenges that have kind of arose and put the kibosh on kind of expanding the program at this point is that the company that created these headsets with wonderful software that has been very helpful for our patients has now been bought by another company, and the software is no longer available and the units are no longer available. So that's kind of where we are at this point. We're just praying that the units don't break down at some point. And the next steps, I think, if we were continuing to use these units, there's a lot of really great environments for exposure. So we haven't really used exposure for anxiety treatment. We've mostly been using mindfulness, but there's literally a bar scene where a patient can go into a bar and we can modify using the tablet what the people in the bar are doing. So for persons trying to resist cravings or kind of like think about coping skills to not use drugs or alcohol, we can have a participant in the bar say, hey, just have one drink. And then we can help coach the patient into like, how do you respond? What do you do in this moment? What are you feeling? There's also different environments for needle phobia and fear of heights, and also social anxiety and school anxiety, where kid can go into this environment and see other classmates in the classroom, like photorealistic people. You can modify the faces so they could look disgruntled, they could look happy. And you can work on exposure protocols with patients that deal with anxiety. We haven't really gotten into that yet, but there's a lot of possibility for helping our patients inpatient really kind of get a head start on feeling better using technology. That's where we are.
Thank you, Dora.
Yeah.
Michelle, if I may ask you a question, and I'll go back to Dora. It sounded like the social anxiety technology, the software and technology was easy to use and went forward without much problem. I happen to know that isn't true. So do you want to speak a little bit to the, since Dora was just speaking about the obstacles that she experienced on the inpatient unit, speak a little bit about how this actually came about and what you really had to do in order to make it work?
Yes, I did make it sound seamless, and it was far from seamless. And we were even lucky because the environment that we obtained was thanks to Joanne's relationships within the community of VR researchers. The environment that we used was actually created for a study looking similarly to Dora, looking at substance use craving, and it was not designed for social anxiety exposures. And we were not able to manipulate the avatars in any way. We were not able to have the avatars speak. That woman saying, "Hi, I'm Marcia, come on in," is the only audio that is in the environment aside from the background noise. So we had to get very creative and scrappy. And what we ended up doing was through an iterative process, actually involving patients who actually had social anxiety disorder. So we sort of worked with people to figure out what would work the best. We created scripts for different kinds of potential social anxiety exposures, where we had, we basically scripted what we thought somebody would say in a party environment. So, for example, we had a conversation similar to what Dora was mentioning, where somebody was peer pressuring the patient into doing something that they didn't want to do. We scripted it very carefully, and then we had volunteers voice act and had that not even programmed into the environment. We had it playing on our phones through headphones that the patients were wearing on top of the VR headset, all because we were not able to program anything. And I'm sure all of the tech people in the audience are cringing hearing the way that we actually ended up having to do this, but it did work very well. And that's part of why this qualitative feedback was so exciting, is that despite the fact that we were sort of, like I said, kind of had to be scrappy and jury rig everything, we still were able to create a social interaction that felt real. We had non-professional voice actors, we had these kind of imperfect scripts, and yet I think it really speaks to the importance of the immersiveness of the environment, and the fact that the patients were part of the process of scripting and figuring out how to make the environment as real to a social interaction as possible. But this was well over a year, that process.
What year was it when you did the study?
It was 2019, and then we were abruptly stopped in 2020.
And the reason I'm stopping you to mention that to everyone is because you said, oh, tech people might be cringing, but actually the technology that Rohan and John and others have been talking about, and well, I don't know if you got to see it this morning, a conversation later, which just simply wasn't available. And so to go to John Rubin's point about just starting with what you have and where you are and kind of gridding it out and going from there, that's what you did. And very effectively. Now, if we were able to redo the study, we could get the people at the party to talk, right, which we could not have done that. So just want to underscore that. And then to go just one more thing, the last panel we were talking about was funding. Michelle was actually funded by the Brain and Behavior Foundation to do this work, at least in part. And so that is an example of a foundation, a well-known foundation nationally that funds junior people to do some cutting edge innovative work. Did you want to add anything else, or?
Well, yeah, to that point about the fact that the technology now is in a completely different place. That's one thing when I think about challenges related to clinical research in VR. is how rapidly changing the technology landscape is compared to how slowly the wheels of clinical research sometimes can move. Our IRB has really changed a lot over the last few years, and approvals move much more quickly. But the reality of how quickly we can make clinical research move compared to how quickly technology changes was another thing. By the time we had IRB approval for the mindfulness study that I mentioned, the headsets that we had purchased, we had the Oculus. I can't even remember which one it was. It was the first generation wireless Oculus that no longer was even being sold by the time we had IRB approval. So that's a big challenge, I think, in clinical research that I don't know if other people also experience, but similar to what Dora was saying about the company changing, we just sort of have to move as quickly as we can move.
Dora, did you have anything else you wanted to add?
Yeah.
Thank you, Michelle.
In what I am really excited by all of the ideas in this conference and the symposium in the last couple of days, and part of what I wanted to talk about also is if you have a research idea that you'd like to implement and think about how it would be applicable to inpatient psychiatry or psychiatry in general. We have lots of clinical faculty that would love to be involved in research projects. And so connecting, I think, the campuses and the different members of our community is really important. Having collaborators that can roll out some of the things that you're doing, I think would be really great. A recent example that I'll give you, one of my colleagues, Tony Ahmed, is working with a team out of Denmark. And Tony is a schizophrenia researcher. So for traditionally we've been treating schizophrenia with medicines, right? So you absolutely need medication on board to help treat delusions, auditory visual hallucinations. But this group in Denmark developed a VR intervention based on the idea that you can also treat psychosis with therapy. And part of the therapy, cognitive behavioral therapy for psychosis is confronting the voices that you're hearing or confronting these visual hallucinations. And one of the ways that was translated into VR is working with the patient to create an avatar of what the voice looks like. And making the way that the voice looks like as close as possible as the patient's imagination, but also the voice. So you can modulate the voice, you can modulate the hallucinations appearance, and then you work with a therapist to confront the voice. So it's really kind of a cool thing to see when you have like this hallucinatory experience in the VR, and it's saying like you're a terrible person, right? Because most of the time it's derogatory things that people hear, and then the patient saying, no, I'm not. Stop saying those things to me, right? And it's really empowering to watch the patient have some agency over these experiences that feel really terrible and uncontrollable. And some of the data coming out of Denmark, it shows that there's a reduction in symptoms, dramatic reduction in symptoms that has a 3-year out, a remission of these hallucinatory experiences. So I think what we can do with VR with psychiatry is the sky's the limit. I think we have to think about collaborating and creative ways to kind of solve the problem. Some of these symptoms are really kind of terrible, and there's not a lot that we can do outside of medications and the treatments that we already have. So I look forward to innovations that come out of the symposium.
Yeah, that's a fascinating idea. I look forward to seeing it in operation. We have about 5 minutes for questions. If anyone, I'd like to open up the floor. If anyone might have any questions for our panelists, where?
Thank you so much. This is fascinating. I was thinking about some of the research I've read about skill transfer with virtual reality environments and how like some educational goals, you'd think, oh, people will learn so much more effectively from this immersive environment. And it doesn't always immediately translate to learning outcomes, but sometimes the more practically like applicable the skill is, the better that immersive environment can help. And I'm curious about, it seems like a lot of people so far in this symposium, and specifically you also were talking about how interpersonal sort of social skills, even if it's like an intrapsychic confronting a voice or dealing with the fear of a social environment seem to be more effectively internalized. I don't, does that seem accurate? Would you, I don't know if there's anything you want to.
I think that's right. And I think even, we don't necessarily think about this maybe day to day, but a lot of our patients that have grown up in traumatic environments don't really know how to express even their emotional state and have been discouraged from talking about their feelings or talking about their needs. And you'll see that a lot of times, in kind of severe mental illness, people will not will have a fear response to just talking about their needs. And so having them, in a safe environment in VR, assert their boundaries and assert their needs and talk about how they're feeling, that could be a lot less scary than doing it in real life with the people that are in their lives that could abandon them or could reject them. So yeah, it's a fantastic way to practice things, extinguish the fear or reduce the fear, and then be able to transfer that to real life.
Thank you, Dora.
Yeah.
Any other
And-
questions? We have a couple, I'm sorry. Michelle, did you want to comment?
I was just going to say that was one of the really exciting things about seeing the patients interact in this social environment was the opportunity to not just kind of coach them, but also we taught them skills the way that we do with any cognitive behavioral therapy patient, and it can be very kind of rigid and manualized, and they're going through a worksheet and they're rehearsing with the therapist, who they're having to suspend disbelief that they're actually interacting with somebody who is might really exist in their real world, and in the virtual environment you actually get to see what it feels like for them, and have them come in and out of the environment and tweak their language and things like that. So that was a very exciting thing about that case series.
Thank you, Michelle and Dora. Any more questions? I know, one over there, anyone? I know we gave you, hang on one second. Anyone over on this side? No? Okay, then. There you go.
Hello. While both of you were talking, I'm really interested in like social anxiety and depression, and anxiety disorders overall. And I'm in a lab where we're doing more like experimental paradigms, like looking at like inducing stress using like the trier social stress test and stuff like that. And while you were both talking, I was thinking about how like perhaps VR could be applied like for stuff like that, like instead of having like an in-person like judge like listening to someone give a speech or something, like what if we use like VR and like had someone actually talk in front of like almost like a crowd of people, and that feels almost like exposure therapy as well in a way. And I was just wondering like what if both of you have any thoughts on like the future of like using VR in research and like experimental paradigms, not only like interventions for looking at like mechanisms and stuff for like anxiety disorders, depression as well.
I think the literature on that is actually more robust than the literature for youth, at least. There is good data looking at using VR for not necessarily exactly the Trier social stress test, but similar assessments of inducing stress. So that's definitely been a part of how VR is applied in clinical research.
Thank you very much, Dr. Pelkovitz and Dr. Kanelopoulos, for your illuminating remarks. To stay on schedule, we're going to move on to the VR for Beginners panel. And so all of you who are on the panel, you want to head up to the front and
Okay, and I think So we have 3 in-person panelists and then 1 panelist connecting remotely, Marielle Emmerich. So I think maybe what we'll do is to both test the sound and to give some voice to the Zoom community. Can we start with you, Marielle? Can you just introduce yourself and maybe talk, we won't talk about your experience working with the patient populations yet, but just review where you are and then talk about the populations of people that you've taken through virtual reality for the first time.
Sure. So hi, everyone. I'm Marielle Emmerich. I am currently a 4th-year clinical psychology PhD student at the University of Connecticut. And I also have a close tie to Cornell. I was an undergrad at Cornell and graduated in 2018. And then since then have been working with Joanne at Weill Cornell for the past 6.5 years. So I've worked with a lot of her studies and different populations. My current research and clinical interests kind of lie at the intersection of trauma and health psychology. So I'm really interested in the comorbidity of PTSD and chronic pain in particular, as well as some other aspects of health psychology like insomnia. And so the work I've done with VR has been primarily in either acute pain patients or PTSD. And more recently, I've been helping out with a study working on insomnia. And I'm happy to talk more in detail about any of those, but that's a little overview.
Thank you so much. Reese, would you mind going next?
Sure. My name is Reese. I graduated from Cornell University with my bachelor's in psychology and a minor in cognitive science. And I've been working with the PATS lab for about 6 months now. This has been my first opportunity using VR. And I am the research coordinator for 2 studies. One we're actively recruiting. And for that study, we're looking to see if VR can help to reduce social isolation for hospitalized patients and be a alternative way to reduce pain outside of pharmacological remedies for that. And the other study that I'm a part of uses VR as exposure therapy for healthcare workers that have some psychological distress. So yeah.
Thank you. So that's 2 populations, and we'll talk more about those particular populations of people being introduced to virtual reality. Jasmine, do you mind going next?
Yes, of course. So I can't see anyone right now because of the sun.
But we
so
can see you. You look
wonderful.
radiant.
Yes, I must be glowing.
Yeah.
But yes, I am Jasmine. So I am currently a 3rd-year PhD student at Cornell University. I've actually been working with VR since 2019, so a couple years before I started my PhD program. As a PhD student, I do research with virtual reality, and specifically, I work with VR accessibility. So the studies that I do all involve various disabled populations, disabled adults, who are almost all usually novel users to VR, because VR in its state right now is very commercially inaccessible to a lot of the different populations I've worked with. So for a lot of them, it's their first time ever touching this kind of equipment. So for a lot of my studies, that's the user group that I work with. As a teacher, and which is what I did before I started my PhD student career, I worked with novel VR users and teaching VR courses at the K through 12 level. So my other group of novel users that I'll tell everybody about is about children from the ages of just below 18 to as young as 9, and a user group that can go positively feral when they're introduced to VR for the first time. So those are going to be the 2 groups I share anecdotes about later on.
That's going to be fun. So Max, if you could go next.
Good morning, everyone. My name is Max, not what my name is Jasmine currently, but I'm a post-baccalaureate student at Columbia and research assistant at the PATS lab. I joined around the same time as Reese about 6 months ago and worked with him over the summer on the social virtual reality study with the older population at New York Presbyterian. I also worked with Marielle on prototyping the VR environment with music integration study that I have the poster over there. And yes, I was a beginner with virtual reality not too long ago, but I learned pretty quickly. I played video games my entire life, so I was used to the controls. But yeah, it's been a very new experience for me and very rewarding.
So you might even be an example of like, you were a beginner to VR. You and Reese were beginners yourself. So you have that still sort of top of mind. So with all of the populations that you've mentioned, we know that there are challenges when introducing people to virtual reality for the first time, and you all may have questions and anecdotes about those challenges. But I want to start on a positive note too, because one of the things that has come up throughout the talk is sometimes we think like, oh, older adults won't want to use technology, or oh, this will be too difficult to use. But actually, we know that there is people are interested and engaged and want to try these new experiences, even if they weren't like built with the populations in mind. So I'd like to open up to all of you and say, like, what surprised you about sort of positively when you introduce people to VR, and then we can go into all of the things that we can aim to improve. So Mariel, I don't know if you want to start or think about that. I know it's been a long time. So.
Yeah. Yeah, definitely. So as I mentioned, I've worked on a couple of different VR studies, and one that I'll speak to, which might be a little bit different from the other panelists, is a few years ago, I was working on a VR study in the inpatient burn center at Weill Cornell. And so we were using a platform from Applied VR, which was kind of like an interactive game that was used in during painful procedures. And so primarily we were using it during wound dressing changes. And if you're more on the medical side of things, you know that wound dressing changes are one of the most painful procedures that patients go through. And so one thing that was really great for me to see was I was actually in the room with them during the dressing change and got to kind of get a sense of like what are their pain readings before, during, and after the VR compared to when they're not wearing the headset. And that was really striking to me because you could really tell that the VR was able to kind of immerse them and take them out of the painful procedure a little bit and provide a really effective distraction. And we know that, VR is much more immersive than using like, a TV or an iPad to play a game on. And so it was really striking to me to see the positive feedback that people had during one of the most painful procedures. So that's probably one anecdote that really surprised me in a positive way.
And a lot of those users, especially if we're going back 5 or 6 years, there were a few people that had experience with VR. So people were able to engage with it as a first experience while having another terrible experience.
Yeah.
Okay, so opening it up to people who are here, any thoughts on things that you saw working with new beginners to virtual reality that you want to comment on? And I'll let you go in any order you like.
So for the older population, their tech savviness kind of varies a little bit more than the younger demographic. It's something that me and Max have noticed when going into the hospital. But for people that are tech savvy, they definitely see the value in VR and are pleasantly surprised by how immersive it can be. We're also working on, so us going into the hospital is phase 2 of using VR to reduce isolation. And for phase 1, me and Max have coded interviews that research assistants did with patients. And we've noticed that they attest to VR being relaxing, especially certain environments. And they also kind of attest to the fact as well that their family or friends would like to join that experience with them. So that's some of the positive feedback. There definitely is more that we've seen so far.
Great.
I don't know if you want to build on that since you're involved in it before I hop in.
Yeah, definitely a lot of positivity when it comes to the environments visually. They do struggle with the controls, especially not being able to see their hands. So when they're in the headset, the triggers are a little complicated for them and where to place their thumbs and moving around. But after probably around 30 minutes of instruction, they get used to it. Yeah, that's probably the biggest obstacle I've seen.
Okay, so that might be a good lead in, Jasmine, because you can talk about both like the populations you've been working with, how people have reacted to it. And then we can sort of move into like, how do you guide people through interacting with headsets when they're really new to it? Like what techniques? I'm thinking when you talk about guiding people's hands, it's like, I have thoughts, but I want to hear yours first.
Yeah, no, absolutely. So with I'll start with the population of disabled adults first. So talking about that group first. And something that you just said, kind of struggling with controls, resonated a lot with me with the experiences that I've had there. So I mentioned previously that almost all the populations that we work with when we're doing accessibility studies, it's their first time experiencing any sort of VR. It's their first time using it. And that can make it really challenging for us to even get past the point of them understanding like what these tools are, what these headsets and controllers themselves are. So kind of two big kind of push areas that we have when working with disabled adults is just two parts of conceptualizing VR. The first one is just the use of VR, I would say, and the second is the usefulness of it. So to tease out that first one a little bit, just to give you an example, when we're working with a blind or a low vision person, we put a headset in front of them, we put some controllers in front of them, and what do they do with that, right? A lot of them have never even touched a headset like this before, have no idea what it's really looking like. They are picking it up, they're touching it, they don't know what they're interacting with. So in that point where we're introducing them to the headset and all of the controls, we take at least 30 minutes where we're walking them through every piece of it. So we're saying something like, just to give you guys an idea, I'll rattle the spiel off the top of my head. What you have in front of you is what's called a VR headset. It's something that you'll wear on your head, kind of like clunky or heavy goggles. If you run your hand along the front of it, you'll feel something that might feel relatively box-like. That's the VR visor itself. That's the part that'll go over your eyes. Now, if you begin to run your hands towards the back of that clunky box, you'll start to feel two straps. There's one that's going to be parallel with the visor in front of you. That one runs along the back of your scalp, so you'll want to place that on the back of your scalp to secure you. There's another strap around the middle of that that's perpendicular. That one runs over the top of your head. And you can see just from that spiel, there's a lot of explanation we have to walk through, and we lead them through as they tactilely explore this headset before we even get to the point of like putting it on their heads. And that's not even going into like controllers and buttons and all of that. So we spend a good chunk of time getting them familiar with this equipment before we even introduce like tools and prototypes and stuff like that. So first, just getting people to kind of understand what they're about to experience is kind of like the first step when we're working with those novel users, and that can take quite a bit of time. After that, what we have to sort of work on is helping them understand how it's useful for them, right? So we've just spent maybe a half hour or even more trying to get them to use something that's clearly not built with them in mind, something that they wouldn't be able to use out of the box. So we sometimes run into a little bit of kind of, dishearteningness, right? Like, oh, this isn't built for me. How am I going to use this after this study? How am I going to apply this in my life going forward? And what I like to do if I'm like working with participants who are kind of in that school of thought is I like to use the antidote of video games, actually. So I'll ask them like, hey, do you like to play games, board games or video games of any kind? And almost all of them do. And then I ask like, well, are those really built typically out of the box vision accessible? And for a lot of them, no, they're not. But there are still large communities who like to play those games. And so we're trying to get across the point really that just because it's not built accessible doesn't mean it shouldn't be, and doesn't mean that it won't be one day if we kind of work on these different things. And that kind of gets people like really excited about it. And actually our disabled adult population is one of our best populations for just kind of like figuring out what needs to change about VR, right? Because that current experience that they have with it is almost unusable for them in a lot of different aspects. So they get really creative with thinking about ways that that experience can change and getting rid of the status quo. Like, hey, let's turn the controllers into tactile maps, for example, or let's make the headset connect to some other apparatus in the room that can tell me more information about how I'm moving around or sonify parts of my environment. They get really creative with thinking about how they want to change this technology to sort of fit the experience that they're more used to. So it becomes, I think, a really great way to ideate on how to push outside of what VR currently looks like. Now that was kind of a long spiel just about the disabled adults.
It was great.
So hopping into the children, working with the children, it's a totally different sphere, a totally different kind of experience that we have there. Because what we have with these kids is we give them, you know, the headsets and the controllers, and they're super excited about it. It's some shiny new tech that they can put on and play around with, and their whole world changes when they put it on their headset, and they're like, wow, this is so cool. But children are not inherently good at VR safety, as you might think or intuit. Guardian boundaries, for example, those like little visual markers of when you're about to run into a wall, not intuitive for most kids. They see those lines and they're like, that's just some other visual effect that I can walk into. And they do. And sometimes they crack the headset. Sometimes they smack controllers against walls. Now they learn by doing. So eventually they start to realize, yeah, I shouldn't be walking into that. But it takes a few times, and sometimes it does break equipment. So it's not the best way to handle things. So like when working with kids, for example, we'll have other kids act as extra guardian boundaries, right? We'll say, oh, if your friends are walking too close to the wall, you start making buzzer sound effects, okay? Because the guardian boundary is not getting their attention. So you start buzzing at them and let them know they're about to run into something. And we kind of like ad lib or add on to safety things. Another interesting one is simulation sickness, like cyber sickness. Most adults kind of, if they start to feel sick or start to get a headache as they're using VR, they kind of know to stop, right? Or to take it off for a little bit, to rest. The kids, they definitely don't. They just keep playing. They don't tell us how they feel. They might not even be noticing themselves how they feel, but they take off these headsets and they like look woozy, or they're swaying, or they're holding their heads. And it was like, you should have been done a while ago. And you didn't say anything. So what we have with those kids is like timers, more additional safety features that these headsets don't come with, right? And it ends up being, I think, with the kids at least, a very cool opportunity to explore ways to make safer VR users who are more aware of the space around them, how they're interacting with the tools, how they feel as they're using the tools, and kind of giving them some outside pushes to be aware of that. Because the kids are like this whole wild sphere where they don't consider any of those things. They're just interested in having fun with what's in front of them. So yeah.
That's such a great example. So I want to pull out two things that you said. And the first one is coming from your discussion of virtual reality as a social experience with other kids, which I think we can consider as sort of like this interesting area of getting multiple people in the VR space. But with the first population, you mentioned that it's a way to envision. It's like what could immersive media be, right? We know they prioritize visual information, but that is just how things currently are. If you think about spatialized sound, obviously you could have a totally immersive environment that could be navigated through audio. So it's a truism, but the idea that if you make an experience more accessible is generally improves it generally. So with that in mind, we move to back to thinking about what are some things that you've noticed in working with naive participants, not somebody who's used to video games and can just put the headset on and observe boundaries themselves, but working with beginners to VR where you're like, oh, this is something that could be more broadly implemented. If we could fix this problem that is not intuitive to a new user, it would improve the experience overall. So I'll open that up. Mariel, I would say just jump in when you feel like it, or we can open it to the panel here.
Sure. Yeah, I think one big accessibility issue is when it comes to I guess our study specifically, we're using a certain platform that requires multiple steps to get the platform going. One thing I've done to encourage motivation is kind of already have the environment loaded before I'm teaching them how to use it to make the task less daunting. But eventually, a part of the study involves me leaving that hospital and them using it remotely. So when they do that, they have to turn on the headset, log in to the platform. If the internet isn't connected, they have to actually type in the password. There's a lot of steps where things can go wrong. And for the tutorial, it may seem a little bit of an overload. They're first getting used to the physical equipment, and then now they also have to get used to the software. So in order to help accessibility, to answer that question, I think it would involve just making a software that's easy to use as soon as you put on. Sometimes the safety boundaries can also be an issue in terms of having older adults specifically that are not as tech savvy, understand what a boundary even is, understand why there's a circle in front of them, and what that's there for, what a stationary versus a room scale boundary is, things of that nature. So kind of, I guess, simplifying that experience would be best for accessibility and I guess avoiding that disheartening experience and encouraging motivation for them to continue to use it. So.
Yeah, and I think that also maybe brings to thinking about how you explain, you get all this visual information if you're able to see it, that can be like, is this a game or is this, a part of the safety features? So thinking about that. And of course, we can turn off boundaries, but in the context of patients in a hospital, we would be reluctant to do that because it's giving good information. Other thoughts?
Yeah, no, I can definitely jump in with some thoughts here. So I kind of talked about some of the aspects of starting up these headsets or using these hardware that is kind of challenging already. But as far as something that I think could be added to really help with more universal accessibility, at least for the two user groups that I've worked with, I would say that having some kind of an audio guide or an audio tutorial that can explain what is in the headset, the UI specifically, like the menus, would be absolutely fantastic. So just to give an anecdote for the disabled adults population, for example, we have a blind collaborator that we work with quite a bit when we're designing our tools and prototyping things. And one of the things he's so frustrated about is that whenever he's tried to use virtual reality on his own, whenever he's bought his own VR headset, like MetaQuest headsets, for example, step one is always he turns the headset on, he puts it on, and it displays a pairing code, right? Like a pairing code for the application on his phone. He is blind. He cannot see this code. The headset doesn't read it out loud to him. There's no audio, there's nothing. It's just a visual code. He physically can't even get past that step to set up the rest of the headset. He has to go to like his apartment neighbor to ask them to put on this headset, tell him what the code is so that he can enter it. So even from that step, that very beginning UI that people come across, having some kind of an audio guide who can read out loud what's on the screen would be great. But for the kids as well, the kids often don't kind of like pay attention to all these different elements that they're seeing on the screen. So once we get past setting up a headset and we're looking at the menu, that UI that most VR headsets have, it's different from like a computer's UI. It's different from a phone UI, right? VR headsets kind of have their own layout, their own kinds of icons. Things aren't necessarily placed where you might expect them to be placed. And so a lot of the kids get kind of like lost when they're moving through these apps. They don't really know what they're interacting with. So having some kind of like an audio guide that can explain, oh, this icon here is for accessing the camera. It contains these sorts of sub functions. If this icon here is where you access your applications, this is what the applications like folder looks like on this headset, would be eminently helpful in getting the kids to focus and find things, but also making it more accessible for someone who can't see the layout to understand what they're interacting with. So I think just having more audio guidance as a default in these headsets would make it much more accessible to novel users of all kinds who are less familiar with anything they're interacting with there.
Very cool example. Max, Mariel, any additional thoughts?
Yeah, I had a very similar idea to the tutorial in the headset. I was just thinking about when you boot up a new video game, you have to go through a mandatory tutorial and you have to get each instruction correct to move on to the next one. So maybe something really helpful would be to something pops up saying, press the menu button to locate the Wi-Fi or the network. And they can't move forward unless they correctly press the menu button and locate the Wi-Fi. I think something more detailed and in depth like that in the headset would be very beneficial, because outside of the headset, it's hard to, really, it doesn't correlate as well as in that.
Even when you have the instructions. So one thing I do want to do is open up to the audience in a bit to both for questions and to talk about other solutions. But Mariel, did you have anything you wanted to add to that?
Yeah, I think one thing that I've been thinking a lot about, it, especially as the other panelists have talked, is really just about how much we want to kind of be thinking about the population that we're trying to target this VR intervention for when designing it. So for instance, I know we talked about some accessibility concerns with patients who might be blind, but then I'm also thinking about the study that I mentioned a little bit earlier in the inpatient burn center. One of the considerations was that a lot of times when patients are getting their wound dressing changes, they're actually lying down, and some headsets, especially when I was running this several years ago, weren't really designed to be worn lying down, and they didn't kind of like accommodate to where your head position was. And so things like that are important to kind of pay attention to when designing these VR environments, and thinking about how we can tailor it to specific populations, I think is so important. And setting up the tutorial, I agree, is going to be a really important step. I think some programs have that already and other programs don't. And then also just kind of keeping the user experience as simple as possible. And I also found it helpful to kind of practice with patients. So, walk them through it, in person the first time you do it. And then if you send them home with the headset, or kind of depending on the protocol, just making sure that they feel comfortable using it on their own as well.
Thank you, Mariel. And I think, well, because this is something I think we all deal with, I'm also interested in opening up this to the audience to ask questions about either questions for the panel about the specific instances they've used, or if you have examples of things you've tried. I know people have mentioned having sort of access cards. So if you can send someone home with a simpler version of instructions that you than they would get through being in the headset, or providing social support in ways to be sort of a remote contact, or how to have a partner to work with people. So I want to open it up to the audience to see if you have any questions. So it's not just me talking at these wonderful students. Okay, I see hands over here.
Thank you. Really interesting discussion. Should we treat older adults that aren't familiar with technology similar to just normal aged adults that aren't familiar with technology? Is there any difference between the two?
I mean, you guys should probably answer first if you work specifically with older adults. I just happen to work with older adults sometimes. So if you guys have like specifics, I can jump in after.
Yeah, you definitely need to remain patient, and also try to have the older adult remain patient, because it's easy to get frustrated. It's easy to get overwhelmed. So maintaining that composure is key. But yeah, just as Jasmine talked about it, initially asking, have you used this technology before? Do you have a smartphone? Do you watch TV? Oh, you do? Okay, great. Well, virtual reality is like a TV, but just, bringing the screen right up to your eyes, and you put it on like ski goggles, using metaphors like that really works well. Reese, do you want to touch on anything else?
Sure. So especially because we're working with hospitalized patients, they're already in a stressful environment, and giving them information on how to use VR can add to how overwhelmed they are. That can be an overwhelming experience in themselves. So simplicity is the biggest factor when working with people that are less tech savvy, and trying to limit the scope of what you're trying to have them engage in is probably a more intuitive decision to help them get the most out of that experience. So for example, if they seem satisfied with one specific feature, not showing them all the features at one time, is a good way to go about that. Also, just trying to be a little bit creative with what the settings, what the features of VR for somebody giving instruction is a good way as well. And an example of that is it's a little laggy, but the Chromecast is a good way to give a tutorial, or sorry, the Questcast or something like that, where basically you can see what they see in the headset from a laptop or something like that. So it's easier to kind of guide them in that way. And once again, just try to keep things simple in terms of that. So, yeah.
Mariel, I know you may have a lot of thoughts, but I actually wanted to make sure we had your question right. So if we talk about, so Reese and Max are talking about older adults because that's a population they're working with, but we know from sort of research of how people use virtual reality that comfort with technology is a factor across all populations, and it does affect how people are interact with virtual reality among other technologies. So I wanted to make sure that I had your question right, though. Were you saying that as a binary, should we think of people who are familiar with technology and people who aren't as different groups, or?
It was actually the binary between older adults that aren't familiar with technology and just adults that aren't familiar with technology at all. So if they do and are familiar with technology, that's completely separate from my question, because it's people that are our age that aren't familiar with technology at all. Should be treating them like older adults as well.
Yeah. I'm going to jump in because we don't want to assume that older adults are all unfamiliar with technology, and then some younger people are and some younger people are. So I'm going to reframe that and say that there's a sort of gradient of technology familiarity across any potential group of user. So I think, and we know that it's important, right? That can really be a barrier to people engaging. So we don't want to say we're going to treat people who aren't familiar with technology as if they were like older, because it's across all age groups. But I will say we've heard some cool specific techniques for addressing technology unfamiliarity. I'm going to summarize like going slowly, especially with patients who are in pain and stressed, as Reese said, who are already going to struggle with taking on something new. Maybe it'll be great distraction, or maybe it'll be additionally taxing. So we've heard techniques like going slowly, being patient, using analogies, providing other kinds of scaffolding. Mariel, Jasmine, do you want to add to other techniques to do that?
So I'd like to ask a question. So we are working a lot with older adults, but there's an assumption being made here somehow that older adults are different, and we're beginning to touch on that. So I want to turn the question around to you younger folks and say, what frustrates you about using the technology, and what do you find difficult about it? Because I know you do, having worked with you. We all do. In fact, we all do, right? And the reason I'm asking you this question right now is because I don't think, in fact, the difficulties that we're having in working with people that NIH defines older adult as 65 or older, and that's how the study is funded. I don't think that they are unique to people who are 65 and older. And I think looking for a bridge in commonalities with our frustrations might be very helpful to you all, but to everyone in this room as well. And again, it's not thinking about it as a continuum, perhaps of frustration or cognitive agility, for example, or you name it. So go ahead, name your frustrations if you don't mind. I know I'm putting you on the spot, but I'm happy to answer two, by the way, if you want me to. But I thought I'd start with you all.
Yeah, but so I'll just jump in here, and then also to kind of like wrap up my answer to that last question as well, and then wrap it into my answer to this new one. So as far as how I'm working with participants of different age groups, basically. As a matter of principle, I try to pose the same questions and ask the same kind of things to absolutely everyone that I'm working with, especially with disabled adults, because that's my adult population that I work with. Because a lot of disabled people are treated in infantilizing ways in their daily lives, right? They're treated as though they can't do particular things just because their ability levels are different. So as a rule, and kind of like a norm in accessibility research, we treat everybody the same way. I think the only difference I have with older adult populations, the only technique difference is that we try to rely more on metaphors of like the kinds of technology they might be more familiar with. Like, oh, do you use joysticks? Have you used these before? What kind of screen readers have you used before? And we bounce off of those metaphors. And then sometimes as another additional technique, we do what we call like temperature checking, right? So occasionally I'll explain a concept and I'll be like, and how do you feel about that? Do you feel you're understanding that okay? And then I just ask that before we move on or go forward. And then we kind of give more or less explanation based on how they're feeling as we go through. But yeah, don't really try to treat them too differently besides grounding our explanations in tech of the time period that they're more comfortable with and that they kind of conceptualize better. Then rolling that into my frustrations with current VR technology and how we interact with technology, I find that I personally end up like anthropomorphizing technology a lot when I work with it. So I think my frustrations when I'm working with it come a lot from things like when technical glitches happen or when an update shows up that I wasn't expecting to show up and then I feel personally slighted, I'm like, the headset is doing this to me on purpose. I also have this thing in my head where I feel that my headset gets particularly like ornery with me when it's late at night. So like post 10 p.m., I'm very wary of working with all my technology because I just feel that it gives me way more issues. At that point in time, I feel like I have so many more bugs that show up and such things as that. So I just feel like the headset and me just don't have a good working relationship in the evening. But as far as like frustrations that I just typically have, I think it's the fact that headsets themselves do end up being like, they feel like updates are being pushed quite a bit. Sometimes they do feel buggier than other interfaces because they're just kind of rolled out and maybe they're not put through as many quality checks before they are rolled out. And there's just so many pieces of the system that can go wrong. So when you're making something or making a tool for them, there's so many different things that can be the problem. And it's not quite clear what it is because there's sensors, there's cameras, there's all kinds of stuff going on. So yeah, I think bugs and unexpected like tweaks and not kind of like being able to single them out as well as like one of my biggest frustrations with VR technology, because I feel like it's a lot easier to single out bugs in other tools and I'm a lot less emotional about them.
And you're a VR specialist.
I am, yeah.
Right. So then that underscores the problem that's been a theme throughout this meeting in terms of rolling out the technology for widespread use, whether it's in a healthcare setting, an educational setting, is that we encounter all of these problems every day. And even people who choose to specialize in it, no matter what our age group, have the same problem.
I have actually gotten so frustrated at one point that I picked up a pillow off my bed and I put the pillow down so that I had a surface that I could fling the headset on safely because I was so upset with it. I was like, let me give you a cushion and then work with me. So yeah.
Burial.
Yeah, I do also kind of want to touch a little bit on the prior question asked as well in my response. I completely agree with what has been said in that, every person is different and has a different comfort level and different needs. And I think it's really important rather than kind of focusing on the group, and thinking about the unique population, but then also the unique individual, right? And so, making sure that person feels like their needs are met. So one thing that kind of I was thinking about too is, we were talking earlier about having kind of like a tutorial at the beginning of a VR environment. And I could also see actually some people getting kind of frustrated with a tutorial, right? If it's mandatory of having to go through, like I know where the menu is, like I don't need to hear, all of these instructions. And so I think with all of these things, just thinking about how we can tailor it. So having a tutorial available if someone is asking for more instruction, and then maybe not having it available if someone is, well versed in technology. And so I think just really thinking about how much we can customize and tailor the experience for individuals. And now with, technological advances, we can do a lot of that. So I think those are all some of my thoughts. And, I would agree with all of the frustrations as well, with the glitches and unexpected things that come up. And maybe part of that too is kind of, if someone's a new VR user, kind of giving them a heads up that, like the technology might not be perfect. You might see some updates pop up, or you might have some difficulty connecting to the Wi-Fi. But at the same time, the benefits to using some of the VR environments can be so great that they outweigh some of the cons. And so I think just even kind of saying that from upfront could be helpful.
Thank you very much. One last question from.
Thank you, Jasmine, for your great presentation. We already have done kind of a study for XR. In our study, we found that, like the thing that you have got from your research, that tech-savvy guys are much better. No matter they have any information about the problem that we are solving with XR. Have you ever done any study to see how long does it take to be familiar with that device? And also, I have another question. In our study, we were working for interventional cardiology, and some of our subjects were very great, kind of surgeon in the hospital. They are great and very confident in that problem. Whenever we are trying to explain how does it work and how we want to use this system, they are not listening to us, And have you ever deal with this kind of problem? And how can we handle this kind of situation? Okay, you are confident in that problem, but this technology is quite different and it's new for you. How do you want to deal with these things?
Got it. Yeah. So for the first question, which is about like, these studies and kind of knowing how long it takes for someone to feel like comfortable, confident, or like they're an expert in something. I haven't run a study yet where we see how long it takes someone to feel like an expert in VR, but we're actually about to start one, a longitudinal VR study where we're going to work with blind or low vision users, and we're going to present them with a variety of different prototyped accessibility tools for VR. And we're going to run longitudinal sessions and take measures over time, basically, to see like when they begin to feel like experts and when they are really comfortable with the system. But we have done a study already where we had two groups of users, one who was novice users and one who were considered experienced users. And this was a study that we did with adults with ADHD or autism who were users of social VR specifically. So in that study, we kind of got a feel for when people considered themselves to be experienced or when they felt that they'd reached like a level of expertise with social VR in our interviews with them. So they mentioned like at the point where they got to, for example, try a variety of different applications when they had been in various different like VR environments and had seen different UI elements and were comfortable basically mapping concepts from one to another. That's when they kind of began to feel that they were the most experienced, right? So it's kind of like if you normally use, I don't know if any of the VR developers in this room would understand this analogy, but if you normally use like Unity, for example, to create VR experiences, and you know the terminologies and languages that are used in Unity, then you switch to Unreal Engine, and you're able to map those terminologies and points over like game objects, our actors, scenes, our maps, that sort of thing. When that mapping becomes kind of more seamless between all the different VR experiences, that's when they kind of felt that they were like experienced users and are confident bouncing between VR. Your second question was more about how to deal with getting people used to the headsets or getting people used to the equipment.
The people that they are, specialists in the problem. For example, for my case, it was interventional cardiology. Some of them are cardiologists that they are very good working with catheter, but they are not good with working with VRs. But when I was explaining how to use the system, they never listened.
Yeah, so when it comes to trying to explain like these systems in detail and people like aren't listening or paying attention, yeah, I think that's more in line with I have had that with some of my studies or some of my participants where they're just either not getting it or where we're hitting a wall. Like the explanations that I give, they're not following along with their fingers quite well, or they're just like getting really frustrated with all the different pieces that they're trying to fiddle with. So as far as like tips and tricks for handling that, I normally try to start from like a blank slate. So I really ad lib it at that point. So I stop and then I ask them like, okay, first, can you kind of give me an idea of what you think about the headset right now? Like, what do you think it is? What are your thoughts on like the controllers? How do you think it's working? And then how do you want me to explain it to you? Basically, what would help you for me to clarify what's going on here if you're still confused? And so I've had people tell me anything from take the headset, put it on my head and move my hands around for me, to someone who said, explain it as though I'm 2 years old and I want you to give me as detailed as possible for every single step. And for that participant, I explained it like from the point of you'll move your thumb on your right hand and slide it gradually to the side until you feel the raised indentation of a button. You will then slide your thumb on top of that button and begin to increase pressure to push the button down. At that point, you will have pressed the button. So like when they're really like confused and just not listening, I just try to ask them like, how do you want me to best explain it to you? And then I do my best to follow those instructions.
So I'm going to jump in and say, I know that part of your question is, how do we get people who are experts in one domain to realize that they are not experts in another? And that goes far beyond working with virtual reality. It's a global problem. And I don't know quite the answer to that other than taking it on an individual basis. But I do want to kind of pull the panel to a close now because we are moving into the workshop. We're going to have a coffee break and then we're going to go into the workshop period. So I want to repeat, if anybody wants to have demos up during lunch break, well, first I want to say, can I please get some applause for our excellent panelists, especially online, Mariel. So people are listed in the program and I think there are many more insights to be gained. So coffee is out. We can have a snack. Please speak to the volunteers at the volunteer table who should be wearing their Cornell swag. If you need help setting up demos, because you will be able to continue demos during lunch. We will now move to at 11:30, we'll move to the workshops, which are looking at specific grant ideas. So the workshop slots are set up out in the hallway. So what we'll do is, don't have my my phone in front of me. So we have 3 workshops. We have the workshop on pain. So the workshop and the workshop signs will be labeled as you go around the corner. Thank you so much, Kevin. So workshop 1 will be applications in medicine, interventions for pain, with me, Dr. DeFede, Dr. Reed, and we'll be in the first room as you go to the right and follow the signs to the workshop. The next one, workshop 2, will be applications in medical education with Drs. Kalantari, Sagaris, and Yoon. And then the third is that will also be labeled as workshop 2 as you continue. And then workshop 3 will be applications in medicine, ENT, and anesthesiology with Drs. Jotwani and Rameau, and that will have a 3 on the sign. So as you come out of the room, you're going to go right and then left to get to those workshops. And if you're leading a workshop, you will be met with a student there who can help you get the set up with any equipment that you might want. So we can do that after you get your coffee. So we'll start that in about 20 minutes. And the workshops will be very conversational. So hopefully an opportunity for you all to talk to each other to generate next steps.
Hi, hello, can you hear me in the back? Hi, good afternoon, everyone. My closing remarks are just going to consist of a lot of thank yous. Thank you to our speakers for an informative and provocative discussions. To all of you who made the arduous trip from Manhattan to the frozen apple up here. Thank you for making that effort. I know how hard it is. And then I would like to thank our volunteers and our students, both from here on the Ithaca campus and those of you who came from Manhattan and then agreed to work even more once you got here. Thank you very much. And most importantly, I would like to thank my colleague, Dr. Andrew Stevenson-Wan, for really doing the heavy lifting on this conference. Since it was up in Ithaca this year, all the logistics were done by her and her team, and that is no mean feat. So thank you very much. And I know we're going to make an effort to stay in touch and take some of the momentum from the conference and the workshop ideas and whatnot, and develop some form of communication so that we hear from one another and can develop even more cross-campus collaborations, which indeed is the goal of these symposium. And on that note, I said I would be brief and I'd say thank you, so thank you. And see you at the next one.
Thank you so much. I also want to thank Isabel McLeod-Daphnis, who did a lot of the work before she was called out of town. So if you see her when she comes back, please give her your thanks. I'm going to say some boring things, which is take your posters, or we will take them and throw them away, which would be sad because they're so cool. And box lunches are on the table back there. So feel free to, after you've filled out your workshop survey, feel free to take that boxed lunch and go, unless you're a volunteer, in which I'm going to ask you to make one 10-minute trip out to my car carrying electronic equipment. Thank you, everybody, so much.